but I can tell you there's always three ingredients. And those three ingredients are having a strategy that the leadership commits to, having a resourcing plan that is realistic and can fund not only the technology, but the business change and the people that needs to go alongside it. And the third thing is the organizational design to bring about that change and make it happen. And those three things are things that I see in more successful programs. Now, these exist everywhere in the world. But I think here, the one thing they've sort of done is they've put in leaders in place that are committed to it. Now, not everything is going to go right all the time. Where does it? But I think at the moment, it's the focus and the drive that's gone behind it to make it happen, to almost become a world leader in this area.
Hello and welcome to The Connection, where RLDatix's Chief Customer Officer Liz Jones and Medical Director Darren Kilroy are joined by leaders and colleagues from within the healthcare industry. In The Connection, we explore how people and technology in healthcare can come together to create great experiences and support patient safety. We hope you enjoy listening.
Welcome to the Connection podcast. I'm Liz Jones.
Hi, I'm Darren Kilroy, Medical Director here at RLDatix. Great to see you all again.
We're delighted to be joined by Sam Shah, who is both a clinician and a lawyer, somebody whose career I've followed for a number of years because of his role in terms of leading digital transformation, not only on behalf of some of the regulators and national bodies, but also I think in terms of leading some of the thought that people have got and their courage and confidence to embrace it. So Sam, we're thrilled to have you with us today. Thanks for taking the time to join us.
Liz, Darren, thank you for inviting me. Really pleased to join you today and very much looking forward to our conversation, especially at this time of the season in healthcare.
Great to see you, Sam. And as Liz was, I'm sure, about to say, we're living through interesting times. I don't know whether it's in interesting or through interesting. I can never quite get this pronunciation, but it's interesting, isn't it? And you must be feeling energized by all that you see around you in the tech space at the minute. Sam, how's it all going?
Definitely. I mean, I'm so lucky at the moment that I get to work in different parts of the world, and it's just great to see the amount of tech that is being embraced, the ideas that are being embraced, but also the change. Some of that change is hopefully good. Some of it is probably challenging for people, but whatever happens, it seems like there's a movement both across the East, the West, and the bit in the middle, where people are looking to technology to enable care, make processes more efficient, improve safety, improve quality, and understand data. And what an exciting time to be in healthcare.
Always nosy me, Sam, on any kind of podcast. Just give us a little bit of a pen picture about your background. How did it all start?
I'm not really quite sure where it started, but I started off working retail technology originally and launching a very well-known e-commerce website many, many years ago. Then went into training clinically, finished and sort of then decided to go to management consultancy, then retrained as a lawyer, and then ended up back in public health, which then took me into digital health. And that was sort of my journey. And I spent a lot of time doing that and then left the NHS and public sector just before the pandemic and went over to work in private healthcare in a private online healthcare provider. And then went to a startup and then stopped all of that and decided to go back to medical regulatory law and international digital transformation. And that's sort of where I am now. So yeah, it's been a nice journey of touching on lots of different things that span, cross, divide, intersect between technology, health, people, and regulation.
Yeah, absolutely perfect for the conversation we want to have with you today, actually. And we'll touch on all of that. I think we're going to touch a little bit. We definitely want to touch on regulation, and how that can quite often be used as a barrier around technology adoption. But again, your experience there is really varied, and you've talked about the fact that you're excited about the time we find ourselves in now. And I thought, actually, just to start us off, if you could share, something that you've seen, that you're seeing happening now, whether or not it's an individual example or otherwise, that you think this is really different. It's different to a decade ago, and people need to watch what's happening in this area or in this place.
It's probably a little bit cliche, but it goes without saying, when I think about the Middle East at the moment, which is where I spend a lot of my time now, the way in which AI is being embraced, and obviously that's a big word and means lots of things to lots of people, and we're not going to be able to define it today, but just the attitude towards using different tools and technology to solve problems, and the rate and pace at which people are willing to embrace those tools and products is incredible. And it's something I've never experienced in the West. I've not experienced it in work I've done in the UK and Canada, in other places. Certainly the intention is in those places. But what I'm seeing in the Middle East is this real sort of super positivity, support from leadership, and at a government level, investment in public services to take on board technology, free up some of the red tape, and solve problems in a different way. So for me, that's probably the big thing right now that is exciting.
If you had to pick one of those ingredients you've just described, whether or not that's the removal of the red tape, the investment, and I really want to dive into how we get people infused, in their roles around this. Which one of those would you absolutely sort of major on if you were going to take that into, say, Canada or the UK or any of the other countries that are trying to embed technology at scale?
I'd love to pick one of those, but I can tell you there's always three ingredients. And those three ingredients are having a strategy that the leadership commits to, having a resourcing plan that is realistic and can fund not only the technology, but the business change and the people that needs to go alongside it. And the third thing is the organizational design to bring about that change and make it happen. And those three things are things that I see in more successful programs. Now, these exist everywhere in the world. They exist in the UK, they exist in Canada, they exist in Australia, they exist in Europe, they exist in the Middle East. But I think here, the one thing they've sort of done is they've put in leaders in place that are committed to it. Now, not everything is going to go right all the time, where does it? But I think at the moment, it's the focus and the drive that's gone behind it to make it happen, to almost become a world leader in this area.
There's the conversation that we're all having and all the energy around AI. 'Cause one of the things that if I talk to my older my parents, the concern is, oh well, this is just going to take away people's jobs. There's going to be no work for people. It's all around cutting costs, and the robots will take over, and we'll all be sidelined. How do we respond best to that, do you think? Because we know it's not really valid, and when we see it in the field, it's not like that. But how have you approached that really common observation that I keep hearing?
And I think we probably all have this, right? We probably all face this, whether it's from older relatives, whether it's clinicians, whether it's anyone that feels at risk, threatened, maybe even not necessarily been given the information they need to make those decisions. And the view I take is that systems don't change overnight. We're living through 2,000-3,000 years worth of history to where we've got to today. Some of those things are deeply entrenched in our cultures, in our behaviors. They're not going to go away. They're not going to, even if I bring all the technology and pour it on all three of us tomorrow, we'll probably still do some of the things that we do right now for the next 10 years. So I think one thing that I try to remind people of is that even if we have the best technology, we think that it might replace some jobs, and it might do. That's going to, take a long time to make the change happen, to give people security, confidence to do that. But the most important thing is we are likely to live through an era where we can't do our jobs without the technology. So it's unlikely probably to alleviate us of those jobs, but it's probably going to create an era where we need the technology as part of a lot of things that we do. And the biggest thing is if we take something as basic as healthcare, take the UK, and we've got things like some parts of the UK with average waiting lists of 55 to 56 weeks, let's say. Well, we know we don't have the capacity. If we add a bit of tech on, okay, it may not remove the jobs, but it might bring down some of those waits, or it might help people get to the services they need a little bit. So yeah, I totally respect people for having those views, and I can understand it must be tough, especially absorbing so much change. But I still take the view we'll probably still be doing the same jobs, but using technology to help hopefully make it a bit better.
How do you think it's interesting because obviously you've talked about waiting lists, and there's a lot of focus on productivity in actually all of the countries that we work with. Darren and I have just come back from a really great visit to customers in Australia, and we had the opportunity to sit down with the Productivity Commission there, who joined us at a roundtable. So productivity is on everyone's agenda for all the reasons we understand, and yet very rarely hear technology really talked about in a health setting as a tool for personal productivity as opposed to system productivity. And I just wondered what your reflections were in terms of that, and whether or not there's something different that we as technologists can do around this.
I think there's two things. One of the problems we've had, and I don't think this is true of either of the organizations you work with, if I look at some of the changes that have happened in the system, often the technology is done to people. It's not user-centric. It's often foisted upon them, and they people don't have a choice to accept something that may have been designed for one environment. They've been trying to, we're forcing it for individuals to use it in a different environment. So that personal benefit isn't always realized. So what the first part is probably trying to be as citizen and user-centric as we can. We design those things, accepting that there's not a one-size-fits-all, and the solution that may have worked in Adelaide might be very different to Sydney, that might be very different to London or Glasgow. And I think you have to accept that we need to allow people to personalize the use of technology for their environments. I think of it like my phone. The way in which I might use my smartphone and look at my email might be very different to the next person does it, but my phone allows me to personalize it in such a way that it works for me. And I think we need to try and think of technology in healthcare in the same way. What components can we allow individuals to personalize to get the best use out of it when they're using it? I think that's probably the first thing. The second thing is our business change model. We very rarely in any health system in the world invest the resource in to allow the business change to take place. The end-to-end journey, we sort of put the tech in, hoping that things will change. And no, that's not enough. We need to change cultures, behaviors, processes, flows. Everything down to a little form might need to change all the way through to the flow for a patient.
I remember in my research days looking at the sociological aspects of some clinicians about why they behave the way they do. And one of the reflections, this is some years ago, I admit, but I think it still holds true, is that people were telling me in the surveys and interviews I was doing with them just that point, that this is when technology was much more archaic than it is now, that they felt that the employer, the hospital, whoever it may be, was interfering with the clinical lives of these people, obliging them to use this or that piece of software, and then expecting them to just get on with it, and then life would be better. And then when it didn't turn out that way, everyone was surprised, because the care had been taken to support people in actually, making sure that they were executing that technology to the best of their abilities. Because for me, any technology that you give to a clinical person, any person really, but speaking clinically here, it's got to enable you to lift the ceiling of your professionalism a little bit higher and take away some of the burden. I mean, looking back on my junior rookie career as a medic, there were any number of jobs I would happily have given to a robot, but they didn't exist. And for me, that was conceptualized as a robot that would roll around and do things like Metal Mickey or something, a proper robot, not on my phone. But that was a bit of fun. But you're absolutely right that if we don't wrap around some holism and some kind of psychological safety netting around how we introduce tech into the workplace, it's not going to work out, is it?
And also, there's kind of the cognitive load, right? Like all the clinicians and people working in the health system, everyone working in the health system in many industries, the cognitive load that they're facing, especially in a healthcare environment where you've got lots of noises and sounds and different departments and different environments and contexts constantly changing. Many people don't even have their own devices that they're using to interface with the system, down to a single machine, a device. And when you're in that environment with so much going on, you kind of get used to a way of working and you just want it to work. You've had enough getting all the logins to get to the system. Now someone wants me to do something else, but I've got another patient in 7 minutes to go and see. I don't have time to context switch to do these things.
Yeah.
And I think well, maybe we've all experienced it, but maybe at a system level when things are being implemented, people don't accept that for those individuals, they're under that cognitive load. They don't have that safe environment, the space to explore, to check, to try things because they're just not given the opportunity. And sometimes I think there's a bit of that realism that's missing.
That definitely is so. And, I think anybody who spends any time in an actual healthcare setting will see things that you think that just isn't the perfect vision that somebody had when they wrote a user case for how said software would be used. And your point is well made, which is we've got to co-create with whether or not they're clinical users or any other user actually. There's a really interesting area now where everybody's trying to redesign what porters' roles are within hospitals. And, there's a group of people that probably know that best, and that's the porter.
And it's probably the little things, right? Like that porter is probably a linchpin in the organization. There's all the things that aren't written down in their job description they do. They probably help people in ways that people didn't realize they do. They're probably doing other jobs and tasks that people didn't realize that actually they're involved in. And so you've got to, this is so classic of health systems where the highest paid person somewhere, the hippos, are making decisions. And I remember this when I was in the NHS, where I'd be with some really senior colleagues who've just been out to see something, or a minister's just said something. Everyone jumps and sort of says, we've got to run for that, right? And 5 minutes ago, the football was being kicked in one direction, and 10 minutes later, because the minister sneezed, everyone goes in the opposite direction. And that was so classic. Things get sort of forced upon the system without people realizing the way things actually work and what people's real jobs are down on the ground. And we think we all need to empower people to be able to challenge that a bit.
And I think there's a role there for tech themselves, right? So again, representing technology companies and what we do. I've always had a problem with the concept of train the trainer, which every tech company uses, including our own. But it relies so heavily on this idea that people can train one another and doesn't take into account whether or not they're good trainers. So that's a great example of how there's probably new ways of doing things with AI. But thinking about the roles and responsibilities. So technology is changing to the point where probably in a decade it will look and feel very different to what I experienced when I first started 30 years ago. Sam, what would you be saying if you were sitting in a sort of closed room now with a bunch of people that ran tech companies about how they had to work with health and care services? What are the things you think they can do better to be better partners?
So much to unpack there. And this reminds me of the days of dealing with all the tech companies sort of back in the NHS. But I'd say one thing is the health system and the care system that we once knew, certainly before today, is probably very different to the one that's going to exist tomorrow. And of course, things constantly change. But I think we're in the next era of change. So what we think of as a healthcare system is probably going to evolve. And that's probably the first thing. Recognize that the system as tech companies knew it is probably no longer the system tomorrow. The person that was in charge yesterday is probably not in charge tomorrow. And so the first thing is probably working out how to build deeper but broader relationships. So not necessarily just with the CIO and the CTO and the CFO, but think wider than that, because they may not exist in the system tomorrow. The second thing is helping tech companies work out, how do they provide a little bit of challenge? Because even if somebody's coming along and saying, I want to buy that piece of software off the shelf and please do X, Y, and Z, look out for the things that the customer is not telling you. The fact that they've got a roadmap of things that they want, but they haven't put them in either the request to you or the RFP or the procurement exercise. But once it's over, they're going to be expecting you to deliver against a bunch of things that they haven't actually asked you about. And you're going to be agile enough to work out, how do you do this and how do you cost for it? So think contingency. When you're having that conversation, start probing on the questions on contingency, because the buyer may be well-intended, but may not have thought about the contingency they need to buy into the relationship. That relationship on the one side has to be dynamic. On the other side, you have to almost accept that you're working in the confines of public sector procurement. How do you balance those two things? So think about a model of engagement as part of that relationship that allows space for that, allows you to continuously iterate, but you build in the mechanism capacity to do that, and try and do that early before a procurement exercise starts. I certainly remember ones for me that have gone wrong and ones for me that went better. The better ones were certainly the ones where we built in space into the contract for innovation. And I think of the national telephony contract being my favorite. We actually built in with the suppliers space for the innovation in healthcare telephony. But there were lots that didn't go so well, where they were so tightly constructed that we left no room for this. Every time we wanted something, it was a change control notice with a cost attached to it. Whereas the telephony one, which is the supplier saying to you, by the way, you do know in this, we've got 5% available for you to decide what innovations or partners you want us to work with. It's not an option. We have to do it for you. Otherwise, you have to give the money back to you. You remember to make sure that we do this. So it was really good having that a different way of working, and it just changed the entire landscape.
So what a great way of working. And it goes back to the point of this podcast, right? Which is even at the contractual level, when you build it, we're not talking there about tech, we're talking about contracts, but we're talking about them in the context of relationships and actually how you work together. So I find that very interesting.
Was then able to bring me things from other parts of the world and say, look, by the way, we're not selling anything, but as part of this, we've got to do this. So we're showcasing for you what's worked in other parts of the world and who we've worked with. It's not stuff we've even done, but other people we've worked with. Here you go. It's yours. And if you want to use it and try it, you can have a go. And it just completely changed the conversation. I wouldn't have come across voice recognition software back in the sort of 2012, 2014 period. Was it not for those relationships? They brought it to the table. They showed how it could work. They ran the proof of concept at no cost to me. And it was a completely sort of game changer.
I was only going to make the point before, Sam, you were mentioning around customer expectation, around them being surprised by what they do and don't want from a certain solution. The link between the procurement teams, in my experience in the field back in the NHS days, between procurement and clinical teams was quite tenuous. And there's a piece of educational work which I think tech can play into, the software vendors can play into here to help customers to better understand how they should articulate what their expectations are and what they require.
I think you're quite right. And I think if we think about it from a clinical point of view, for those of us that were in public health, it'll be about commissioning healthcare services. For those that are probably on the clinical front line, it will be about technology, devices, everything from syringes at one end through to the scope at the other end, right? And so it's normally that sort of thing that we would probably be closest to. And that's quite transactional. Those things are actually almost quite easy. They're very transactional relationships. Whereas the sort of things we're talking about and the type of technology we're thinking about, it's much more relationship orientated. And so the thing that probably changed it for me were the procurement teams that work with government digital services. When they came across, they came with a different set of attitudes and behaviors to the procurement teams I was used to working with. And that, for me, it's those procurement people that are probably most relevant for health tech, more so than the traditional procurement people that are used to buying syringes and drivers and those sorts of things, right? And there was someone, I won't name him on this podcast, and I still am in touch with him. And he completely revolutionized my view of procurement and how I should use procurement. And basically, it's taking agile procurement methodology. It's like, bring them in at the beginning, bring them to see the problem, make the procurement experts understand what it is you're trying to achieve and what the problem is that you're facing, and make them part of the problem. And ask them to literally stay with you, handhold you the entire way through. And that changed things. That completely changed the way in which I approach procurement from that day on.
Sort of really interesting. Moving it on a little bit to think about barriers. So, Sam, you might have some insight here. I'm still amazed at the conversations I get involved in around IG, particularly. I'm going to take it to the UK for a minute, and around sharing within our own system. So within the NHS, even let's not even be as lofty as to think about sharing across Wales and England. Let's just make it England, or even actually let's make it a region, right, within England. It's bizarre, but it feels like it's got worse, not better. You've also got two minds to look at this. You've got your experience, well, three: digital, clinical, and your experience in law. Can you unwrap this puzzle for me? I'm bewildered by it now.
I think this problem is universal. I've been having conversations, in fact, today with colleagues from Australia, Canada, across the Gulf region, even my own role, and the NHS today, in fact, all around the same thing. And the same problem pretty much exists everywhere. And it's very rarely about law regulation. Classically, it's either about behaviors, cultures, sometimes it's about understanding. But normally, in most countries in the world, law and regulation generally permits sharing where it's in the interests of an individual receiving clinical care. That is generally the principle. Now, we have a slight quirk in a place like the UK, and particularly England. We sort of have this concept of call the cops. That's an old concept now, but existed and predates the existence of Data Privacy Acts and Data Protection Acts and GDPR and those sorts of things. And that meant there were a certain sort of army of people and teams that got created to behave and operate in a certain way for good reason, for absolutely good reason, to protect individuals' rights, data, so forth. But then culture moved on, society moved on, the law moved on. And we ended up with a European directive that existed whilst the UK was still in Europe. We then have local law to make up for some of the things that the UK wanted that were specific to the UK. And then we have a post-Brexit period where there is UK GDPR and the Data Protection Act that still exists. Now, if we go back to basics and what the law basically says, as long as you can justify what you're doing and it works within the law and regulation, you can pretty much do it. I'm simplifying, I'm probably oversimplifying, but that in short, that's where the position is. So many people get themselves hung up on types of consent, levels of consent. They get themselves hung up on perceptions of organizational policy. And quite often, those things are not designed in a way to be prohibitive or to be obstructive. They're often designed in a way to make things happen. And it's because we haven't necessarily given people the freedoms, and people are fearful. They're fearful of what happens if I get it wrong. Will I get in trouble? Will I get referred to my regulator? And these are things we deal with. And I in certainly cases I've dealt with where people have been referred to their regulator for doing things they're completely allowed to do, but someone's got trigger happy and the regulator themselves doesn't understand. The GMC or the NMC or the GDC doesn't understand. And people sort of end up called in front of the regulator for things that are completely lawful. So I can totally understand why people's behaviors exist in a certain way. And I think to overcome this, we've got two things. One is helping people realize what the guardrails really are and where they stop. But actually, probably now, using technology in a better way, for technology to support people with that decision making, we shouldn't expect people to understand this stuff inside and out. They're not all lawyers. Why should they? Why don't we build the technology in a way that gives people the cues and the questions that allow them to overcome this? If they want to share, it's almost like do you really want to share? The rules allow you to do this. Is this the scenario you're currently in? Yes or no? And if they say yes, these are professionals. We can trust them to do lots of things. Let's trust them to make those decisions and allow it to happen. And I actually think for the system, we probably have less people working in IG in those roles because we've designed systems to allow that stuff to happen and to pick up when sharing shouldn't happen because, we've designed a system around this. So I feel sympathetic towards the people working in the system, and these are our colleagues. And I also feel sympathetic to the people who are supposed to be custodians of the system because we haven't really created the tooling for them to do their job in the right way. And a great example of this for me is the concept of super controller. I'm kind of for the concept of super controller. Finland, Estonia have gone towards a super controller model. I think the UK probably needs to go towards this concept. That means we're not taking away controllership of where data is controlled. We're definitely not training ownership. The data belongs to the person who it relates to, the citizen. But we're creating a supervening controller, and I think it's needed for health, maybe at the 4 nations level, maybe at a national level, where those rules are set at a national or operator level. That doesn't change the localization, but at least it creates some parity that would get around all of this. Can I share? Can't I share? Who's allowed to make the rules kind of thing?
We're not going to talk about the news today in terms of the changes that are happening within the health system in England, but that combined with what's happening around the 10-year plan, there's an opportunity there is an emerging opportunity if there's going to be a change anyway around leadership and legislation.
Any change globally, right? When you're going through those moments of change, whether it's the US, Canada, UK, elsewhere, and England at the moment, as an opportunity to think differently. And if we're going to bring about some differences for positive patient benefit, for citizen benefit, maybe this is one area where we can positively come together to work out, is there a different operating model?
I'm always interested in looking back at every guest if I can ask a question around the pandemic experience, which wasn't that long ago. And as you were talking there, I was thinking about the liberalism of regulation that came around during the pandemic when there was a much more permissive mindset. And lots of us working through the pandemic, for all the tragedy and distress of the pandemic, found that a very liberating time to be a professional because you're actually given some autonomy in a way which had been clipped in previous experience. I wonder what your reflections are on your time through the pandemic in your roles and how you felt or didn't feel a change in how technology was able to expand into that liberalism or not.
I've got 3 lenses to this. The first is, as my previous responsibility is the senior responsible officer for government, responsible for the technology that was supporting the pandemic piece. And that was prior to this pandemic. And that was part of my remit. So if I look at it through that lens, first of all, we'd already designed a system in shadow ready for when a pandemic happens. And the rules are already built into that. So at the point at which the population is more at risk and death is imminent, we switch over into a different model, recognizing the risk of not doing something is far greater than the risk of doing it. And the architecture was ready for that from a technology point of view. I then look at it through what happened during the pandemic, and I decided to go back to clinical practice at that point for more of my time than less of my time. And I think about the problems we were dealing with. And we were dealing with the problems, the fact that that moment we didn't have vaccines available. We didn't know what was going to happen. We had to do the best we had to do to help people survive, live, exist. And it gave us the freedom to almost go back to first principles around both clinical practice, but operationally how we behaved as well. And we had to develop rules and procedures on the hoof in some cases. And I had one of the first urgent care services in London that was stood up. And part of that was, well, I'm a public health professional that is trained in infectious diseases, and I'm a clinician that still practices. It's almost incumbent on me to go and do this stuff.
Yeah.
And I had people had to trust the fact that I knew what I was doing and I had enough knowledge of both those areas to start making things happen. But it helped being both camps in a technology space, operationally and public health, doing those things. But you were given trust by the system, which sometimes as a clinician is not always so easy, right? Because systems are designed with management layers and decision-making layers. But at that moment, people trusted you. But the third lens I look at it through is what happened afterwards. Why did some of those things regress or change? And part of it was that we had to go back to delivering all the other things that exist. The system couldn't simply just spend all its money on fighting a pandemic and giving people freedoms and indemnifying people against that. So I think when the risk of death was there, of course, we switched over and changed. Once the risk of death perhaps wasn't so great, we had to also go back to doing some of the other things that we kind of left and were building up and waiting in background, which meant some rules were also needed.
And we are going into it off the back of that experience, right? And 5 years on, everyone sort of thinks that it's the deep dark past, but it's not. It's part of the nation's lived experience as well.
It's now part of our culture, right?
Absolutely, yeah. And depending on your age group, you come to that with so many different experiences, and it takes me to where I was going, which is actually part of this podcast. We believe that these are really interesting, fulfilling jobs, whether or not you go in whatever part of the health and care sector you choose to work in. We would encourage people to do it, partly because we hear stories like yours where it's just such a rich career of so many varied experiences. And what real advice would you give them in terms of how they go about it and where they look and what they're going to get from their careers, especially with this tipping point in technology that we're in now?
The most important thing, and I say this to anyone that asks me about careers in any part of health or tech, which is first of all, do something you enjoy, do something that you wake up in the morning wanting to do. And when you no longer do wake up in the morning wanting to do it, do something else. And so don't be afraid of doing it, but don't be afraid of changing. We no longer need to have one career or one profession. It's okay to switch every few years if you feel like it. And if you don't and you want to do the same thing, that's also okay. So what I try and assure people with, whether it's young clinicians or anyone else, which is don't be afraid of change. Actually embrace it and be willing to accept we're all going to have portfolio careers of some variety. Some will have bigger portfolios, some will have smaller portfolios, but don't worry about it. It will happen. The next thing is make sure you're kind of willing to adapt. The technology is going to face us in every part of what we do, whether it's our personal lives, our professional lives. Go with it. Try and embrace it. Try and explore and ask the questions. Ask the curious questions, because you might ask a question for something that someone hasn't solved, and you might be asking the next question that needs to be solved by technology. And there are always new things to solve. So always be curious and ask those things. But the final part of that is also probably a slightly odd thing, I'm going to say, but it's to be militant. Stand your ground. Be absolutely excellent at what you do, but be militant. Be willing to stand up for something you believe in or you think is right. Because don't be that person that can watch something, see it kind of unfolding and going wrong, but be the person that stands up for something you believe in and for the change you want to see, because we are that change. So yeah, those are my 3 bits I kind of try to tell people about. And what I might do or someone else might do, that's for them to do. And I'm not going to say to somebody, do the thing I've done. That's my experience. I'll share my experience, but make your own experience.
Absolutely love that, and I think that's advice for people at any stage in their career. But it's interesting now, as I get towards the end of my career, and as you start to think about actually portfolio careers, the different ways we're going to work. People, lots of people are going to have to work a lot longer. And won't necessarily retire. So all of those points you make are applicable actually for any part of the for many people at different generations.
It's just been great to talk to you and have this chat. We should do it again sometime because there's other things to talk about.
I've loved our conversation, and I think I've taken as much from it as probably hopefully you've asked me about, because there's things you asked me about that really made me think, and they'll probably stick with me for the next few weeks now when I think about them.
Cool.
Well, thank you
Great.
so much. I think we've learnt loads. I think there's just, in summary, I think there is some your enthusiasm is really important, but also some of your practical examples of what that really means and your empathy for the people this is going to happen to. We'd definitely love to talk to you again. Love to talk to you about equality and tech in particular when we think about citizens and as this all starts to sort of like seep out from care providers through to our homes. Maybe you'll let us revisit you at some point, Sam.
Yeah.
Gladly and happily. It's been a real pleasure joining you today. Thank you so much.
Thank you for joining us on today's episode of The Connection. We hope this episode has provided you with valuable insights on the role that both technology and people play within the healthcare landscape. For more information and resources, visit RLDatix.com. Don't forget to subscribe to The Connection on Apple Podcasts, Spotify, or any other podcast platform you use. Join us next time as we continue to explore how healthcare is impacted by connecting people and technology. On behalf of the RLDatix team, thanks for listening.